We'll start by taking a look at the mitral valve. Here we can see it from a surgeon's view. If we tilt the heart backwards, we can see the mitral valve annulus has several curves. As we continue to rotate the heart, we see that the annulus curves across two planes and bears a shape similar to that of a well-known stackable potato chip, which, mathematically, is known as a hyperbolic paraboloid. And just like the Pringle, the mitral annulus curves along the anterior-posterior plane, as well as the anterolateral posterior-medial plane. Looking at it from above, we can once again see it from a surgeon's view. But further complicating its geometry, but explaining the naming convention of its landmarks, is the fact that it's situated in the heart at an angle when viewed from the coronal plane. Here we see that the posterior medial commissure is more medial than that of the anterolateral commissure. Interestingly, hyperbolic paraboloids can be found in other facets of nature and are believed to be integral in allowing the mantis shrimp to pack a deadly punch. The mantis shrimp, seen here punching a crab, can deliver a punch with the same force as a .22 caliber gun, despite its small size. But producing such a high-speed punch wouldn't be possible by muscles alone. But the somatopod leverages the mechanical design of the saddle-shaped joint to store a great amount of potential energy before releasing it as kinetic energy. The mechanism is illustrated nicely in this animation from the YouTube channel Smarter Every Day. And just like the joint of the mantis shrimp, the mitral annulus compresses along the AP axis during systole and expands during diastole. Importantly, in pathologic states, such as mitral valve prolapse, particularly with significant annular disjunction, the annulus paradoxically expands during early systole rather than compressing. Mitral valve prolapse is defined by mitral valve displacement more than 2 millimeters above the mitral annulus in the long axis view. If it's less than 2 millimeters and the coaptation point is below the annulus, it's considered billowing. And if the undersurface of the mitral leaflet tips, flip up into the atrium, it's considered flail. Mitral annular disjunction is characterized by the atrial displacement of the hinge point of the mitral valve annulus from the ventricular myocardium, and can occur either in conjunction with bileaflet mitral valve prolapse or independently. And finally, there's a phenomenon of pseudomad, which is characterized by the illusion of annular disjunction, which may occur when the posterior mitral leaflet abuts the left atrial wall during systole. And although mitral annular disjunction was first described by the late Johns Hopkins pathologist Grover Hutchins in 1986, rigorous research into its arrhythmic potential didn't take off until the 2010s. But as mentioned earlier, during normal physiological circumstances, the mitral annulus expands during diastole and compresses during systole. When mitral annular disjunction is present, the annulus might look normal during diastole, but it expands during systole. On the left, we see two movies from cardiac MRIs, for which the speed has been slowed down to 40% to more easily track movement during systole and diastole. The leftmost movie is from a normal heart without mitral annular disjunction, and we can see the mitral annulus compresses during systole and expands during diastole. The movie on the right is from a patient with mitral annular disjunction, and we can see that during systole, the annulus expands as the basolateral myocardium appears to thicken. This motion has been described as systolic curling. During this expansion, the lateral annulus moves apically at an accelerated rate, producing high tension at the insertion site of the basolateral myocardium. This can be visualized on tissue Doppler of the lateral annulus in the form of a high-speed spiked-appearing systolic waveform, which has been termed the Pickelhab sign due to its resemblance of the spike on these German war helmets. Mitral valve prolapse can be expected to be found in about 2 to 3% of the general population, affecting about 10 million Americans and 240 people worldwide. It's important to recognize, however, that prior to 1987, mitral valve prolapse was grossly overdiagnosed, being reported in up to 1 in 6 echocardiograms. This was prior to the appreciation for how the saddle shape of the annulus can affect the appearance of valve height in different echocardiographic planes, with the 4-chamber view particularly contributing to overdiagnosis of prolapse. But in 1987, Drs. Robert Levine, seen here on the left, and Dr. Arthur Wayman, seen here to his right, highlighted the effect that the saddle shape of the mitral annulus has on mitral valve imaging. In the figure on the left, they draw attention to the fact that the apical 4-chamber view intersects the mitral annulus across its highest points, eliminating overestimation of mitral valve prolapse. But when the beam is tilted, as in the apical 4-chamber view, it intersects the annulus across lower points, creating an illusion that the mitral valve is prolapsing. They then did an experiment where they rotated an ultrasound beam 360 degrees around the mitral annulus, and showed that when the beam was in the 0-degree position, it intersected the annulus at the lowest points of the saddle, but that when rotated 90 degrees, it intersected the annulus along the highest points of the saddle, and that this pattern repeated as they continued to spin the ultrasound beam. Now looking at the heart through the barrel of the left ventricle, we can see what happens when an ultrasound beam intersects the heart in the apical 4-chamber view. We can see that the beam intersects the annulus not at the lowest point or the highest point, but somewhere in between, just as depicted in the initial diagram by Dr. Levine and Dr. Wayman. Similarly, when the annulus is transected, as it is in the parasternal long axis view, the beam cuts through the annulus at its highest points. If the annulus is used as a reference point to define prolapse of the valves, we can see that when viewed in the parasternal axis, the valves do not rise beyond the Bloom beam, but that when viewed in the apical 4-chamber view, the perceived lower height of the annulus creates the illusion that the valves are prolapsing above the entire annulus. But as mentioned earlier, modern estimates suggest that mitral valve prolapse can be found in about 1 in 30 individuals. Mitral annular disjunction, on the other hand, seems to have a much higher prevalence, which is dependent upon the imaging modality used to examine the mitral apparatus. Review of 1,400 consecutive echocardiograms in Japan revealed mitral annular disjunction in 9% of the population, with only 1% of studies revealing concomitant prolapse and disjunction. Review of 2,600 cardiac MRIs from the UK Biobank revealed annular disjunction in 75% of individuals, with about 3% having concomitant mitral valve prolapse and mitral annular disjunction. However, among patients with concomitant prolapse and disjunction, the prevalence of disjunction greater than 6 millimeters was less than 20%. Cardiac CT, having the highest imaging resolution, revealed annular disjunction in 96% of a cohort referred for cardiac CT in Japan, with the highest frequency of disjunction occurring in the anterior and inferior commistures, rarely being found in the inferior lateral wall.